Welcome to the fifth episode of the GIFT webinar series called Women Up to No Good. Women Up to No Good is a series where we ask the questions that matter most when it comes to female sexual and reproductive health and how research and innovation can improve this. This webinar series is an initiative of the GIFT project currently being led by the University of Cape Town. In the chat box, we will post a link to the GIFT website in case you are interested to learn more about the device and the team. For those who've just joined, my name is Mona Lisa Manandra. I'm a researcher at the University of Cape Town working on the GIFT project. Welcome to the fifth episode of Women Up to No Good. In anticipation of World AIDS Day, which will be on the 1st of December, we've brought together a panel of expert researchers to discuss the challenges of HIV prevention in women, from understanding risk perception to identifying motivations for prevention. In line with this, our panel will introduce key findings from a recent groundbreaking study on subcutaneous lenacapavir involving over 5,000 adolescent girls and young women. Our panel will also discuss how both actual and perceived risk are key motivators for women considering PrEP. So this webinar will follow a structured format, beginning with our two experts, each reflecting on today's topic. We will then move into an open Q&A session where you are welcome to ask questions via the chat box. Please be aware that this session is being recorded and will be available on the GIFT YouTube channel. This is also where you can catch up on webinars from this series that you may have missed in the past. To ensure you don't miss out on upcoming dialogues and other important announcements, I encourage you to sign up for our e-newsletter and stay tuned to our GIFT media channels. We're excited to have such a good turnout today. Please continue to introduce yourselves and engage in the chat box. And don't hesitate to use the chat box for any questions at any time throughout the webinar. Questions for panelists can be added to, and we will address them at a later stage. So it is my absolute pleasure to introduce our panel of experts today. We have our first speaker, Professor Linda Gayle Bekker, who is the director of the Desmond Tutu HIV Center at the Institute of Infectious Disease and Molecular Medicine at UCT, and Chief Executive Officer of the Desmond Tutu Health Foundation. Professor Bekker is a physician, scientist, and infectious disease specialist. Her research interests include programmatic and action research around antiretroviral rollouts and TB integration, prevention of HIV in women, youth, and men who have sex with men. Our second presenter will be Dr. Devorah Joseph-Davy, who is an infectious disease epidemiologist with extensive experience in design, management, and evaluation of HIV prevention and sexually reproductive health programs. She is an associate professor in the Department of Medicine, Infectious Disease and Epidemiology at University of California, Los Angeles, and an honorary associate professor in epidemiology at the University of Cape Town, South Africa. She's based in Cape Town and has been actively engaged in global and South African policy on HIV prevention and sexually transmitted infection diagnostics and treatment in pregnant women and their families in sub-Saharan Africa. She leads several NIH-funded studies on STIs, HIV prevention, and pre-exposure prophylaxis, or PrEP, in pregnant women and breastfeeding women in South Africa. So without further ado, I would like to invite each panelist to start this discussion with a brief scene setter by giving some insights into this topic based on their background and experience. So over to you, Prof. Linda Gayle.
Thanks, Mona, very much indeed for the introduction and the wonderful invitation. And what a pleasure always to share a platform with Devorah. So thanks, Joanne, too, and congratulations on the terrific GIFT project, which continues, I think, to offer great promise. So I'm going to actually go beyond lenacapavir this afternoon because I really want to expand our thinking about PrEP for the future and very much the era of choice. But what a pleasure to be known as a woman who is often up to no good. And this, of course, is the study in question, two of them Purpose 1 and Purpose 2. Purpose 1 was run in Uganda and South Africa amongst young women aged 16 to 25. And Purpose 2, as you can see, in diverse populations around the world. Both of these studies come together to provide the dossier to go to regulators for licensure. And the reason we are applying for approval is because of these fantastic results. So 0 infections amongst 2,000 odd young women who received lenacapavir in a randomized controlled trial, which was blinded. And you can see that 0 infections occurred in those 2,000 women over a 1-year period. And in Purpose 2, just 2 infections amongst a similar 2,000 people who received lenacapavir over 1 year. And following these wonderful results, which I had the great honor of showing in Munich, many people have come up to me and said, well, that's done. We don't really have to worry about prevention anymore. Maybe we can just all forget about it now and move on to climate change. And I want to just temper that enthusiasm a little bit to say, I think we do still need to think about bringing everything we know about primary prevention on board. And the reason is because we really are not there yet, and we have a great deal of work to do. So as you can see, this is what the 2030 UNAIDS targets required of us and where we actually are. So we really do have a lot of work to do in order to reach those, targets of new infections per annum. And the first 30 years of the AIDS epidemic quite rightly centered us on treatment. People were dying, there was an emergency, and there was very little innovation around primary prevention, really relying almost entirely on the latex male condom, which does remain cornerstone to our prevention. But I am delighted that we have moved beyond abstinence, be faithful, and condomize. And we are now in the era of antiretroviral-based biomedical prevention. Many years ago now, we asked the question, can a pill a day prevent HIV? And that would be prophylaxis as we know it. And yes, there is a resounding yes, a number of clinical trials now completed in different populations that absolutely confirms that when a combination of 2 antiretrovirals are taken every day, this is highly effective at preventing HIV. So now we do have this wonderful, what I like to think of as a prevention train. Any method of prevention can roll up as your carriage in your station, and that may be applicable for you. And that might vary from time to time, depending on where you are. But central now, and for the last decade, we really have seen innovation in the field of pre-exposure prophylaxis, particularly ARV-based prophylaxis. And as mentioned, what holds promise is this concept of immune-based pre-exposure prophylaxis, or BNABs for PrEP. I'm not going to focus on that today. I'm really going to come back to the antiretroviral-based PrEP. Now, a minor digression here to say there are 1.5 billion vehicles in the world today. Many of you may drive a car, and your dream car may depend on a variety of different needs or desires you have today. You might want a car because it's very safe, or you may choose a car because it's very fast, or you may choose a car because it's very economical, or because it can carry a large family, or, and so on and so forth. The point being, each of us has different taste and different needs at different times. And similarly, it should be like that for prevention, because indeed humanity comes in many shapes and forms, and we believe that prevention should too. So pre-exposure prophylaxis is one part of prevention, and of course now we believe that PrEP itself should come in many shapes or form. And we're starting to see data now that confirms that with tailored, accessible services and choice, we may expect better coverage of all people and better coverage of all exposures. So the SEARCH study has been running in Uganda and Kenya for a number of years. This is a community-based option for prevention for populations in those two countries. They have now added injectable PrEP as well as oral PrEP and PEP within a dynamic choice intervention. And they have shown, and this was presented at CROI this year, that by offering this choice option, there was a greater than 5-fold coverage of all exposures and a reduction of incidence to below 0%. We also get lessons from reproductive health. And of course, with the introduction of long-acting reversible contraception, we now know that many more women can adopt the right contraception for themselves, and we get better reproductive outcomes, even amongst young women. So here in the inset, you see young women aged less than 21 actually getting really good reproductive outcomes because they now have the choice of long-acting reversible contraception. So I want to introduce today the concept of PrEP as a 3-dimensional concept. So we have the opportunity to think about the kind of PrEP we offer people. Is it short-acting? Is it long-acting? Is it event-driven? What does it look like? How we deliver it, maybe we give it to you in a clinic, or we give it at school, or we deliver it in a mobile, or you have it sent to you by courier. And we think about the individual, the user. Does that person have a needle phobia? Can they take pills every day? Do they want only event-driven PrEP? So this is the concept I want to expand on in the next few minutes. So let's start with pill options for PrEP. This is a good old friend, been around for a long time. FTDF, it's a tenofovir with emtricitabine, and it has been shown in a number of studies, highly well established now, that oral PrEP is very effective for both women and men. This gentleman, Pete Anderson, working together with Al Liu in the STRAND study, showed very nicely that actually it doesn't have to be daily, but even 4 doses a week is as effective, because of the PK of the drugs, as effective as 7 days a week in terms of effectiveness. And for a long time, because of some pharmacokinetic modeling, we believed that women needed to still take 7 doses a week. And I'm pleased to say that Jeannie Marazzo has now published cohort data that supports that even for women, 4 tablets a week is more than adequate in terms of effectiveness. This led us on to be able to work on an event-driven process. And so here you see the 2-1-1 regimen, which is now really getting into a number of guidance all around the world to show that when men take 2 pills, 2 to 24 hours before sex, 1 pill 1 day later and a pill the next day, this is as effective as oral PrEP on a daily basis. Again, women have been left behind. We have not seen trials in women, but there is PK dosing and modeling now to show that a 2-2-2 schedule may be adequate for women. And in fact, the Beaver guidelines in the UK have gone on to say to 2 pills pre-sex and then 1 pill for 7 days afterwards is within their guidance. And if you want a quick start, you should double up your pills. People then went on to say that we heard this often, that oral Truvada is too big, it's too difficult to swallow, and clinicians were worried about side effects in people, particularly where there were renal or bone abnormalities. So here is a close cousin called emtricitabine with tenofovir alafenamide. This has better PK, fewer side effects, and this has been shown to be non-inferior to oral Truvada. We did not have data in women, but Purpose 1 introduced FTAF. Unfortunately, we did not see effectiveness in the study across the board because, as I will go on to explain, women struggled again to use the pills daily. But in a matched controlled study in Purpose One, we were able to show that those people who took FTAF definitely saw effectiveness. What else is coming in the pill department? Well, we have a dual prevention pill that is being studied. This is a mixture of oral contraception and oral PrEP. And that study, the bioequivalent study, is underway at the moment. And then, of course, hugely anticipated, there is a monthly pill with a nucleoside reverse transcriptase translocation inhibitor known as MK8527. The phase 2s will be finishing in January, and the phase 3s will be starting next year. So that one we are looking out for. What about the topical options? Well, again, we know Dipivirine ring very well. The use of the vaginal ring to prevent HIV on a monthly basis, 2 studies with modest results, although we know, again, as women have got to use it more, we're seeing better effectiveness. We now know there is a longer-acting DAPI ring. This was introduced to us at R4P, the PK, both inferior and superior to the monthly ring, and we really hope this will drive the price of the DAPI ring down. I think Devora will talk about how we're hoping this will also be rolled out to pregnant women, but we now have data in pregnant women and in breastfeeding women that the DAPI ring is safe. What's coming in topical PrEP? Well, there is a fast-dissolving vaginal insert under investigation, a Dipivirine vaginal film, which lasts for 30 days in the vagina, is under investigation. And this very sexy ring called the One Ring has a compartment for contraception on one side and for an anti-HIV option on the other side. And they can be self-inserted, and you can change your inserts as you need. For people who engage in anal sex, there is a rectal douche with tenofovir, also under investigation now in phase 2s. But let's turn quickly to injectable PrEP. First of all, cabotegravir long-acting. This is the 2-monthly. It's been with us now for a couple of years. We know that it works for men who have sex with men, transgender women, and for women who have sex with men. This was the first time we saw brilliant results in women. And we are very excited about the 2-monthly intramuscular cabotegravir, which is, of course, an integrase inhibitor. There is now an ultra-long-acting CAB under investigation. Initially hoped we could do it subcutaneously, but in fact, that was shown to have too many side effects. So the ultra-long-acting intramuscular formulation is under investigation and hopefully will be with us soon. That will be a 4-monthly injection. And here, of course, I bring you back to lenacapavir, a 6-monthly injectable given subcutaneously. This is a novel mechanism of action. It's an HIV-1 capsid inhibitor. And because of its potency and its long PK, we can just give 2 shots every 12 months. So again, to make the point, there is a Purpose One that is complete. Purpose Two, these two are going together to our regulators. And it has been shown already in Purpose One to be safe in adolescence, safe in pregnancy, and safe in lactation. So we're very excited about a broad approval for that product. Why did it not work so well in the oral FTDF, which was the active control? As you can see, young women, although they may have started quite well, fell off quite rapidly in terms of their use of oral FTDF and FTAF on this occasion. And when we look at the annual persistence, you see annual persistence to len injectable much, much better than that of oral FTAF or FTDF. So unfortunately, this population of young women, as we have seen time and time again, really struggling with the daily option and the injectable offering much more. There are going to be individuals who don't like needles. Here is the injection site reactions. Whenever there's a needle, there is pain. There may be swelling. And in fact, the way it works is you create a little nodule under the skin when you inject the lenacapavir, and then that dissolutes over a 6-month period. So there is a nodule that which may be palpable, it may even be visual for the first little while, and then it disappears over time. And what you can see is over a period in both Purpose 1 and Purpose 2, people became more tolerant of the pain, the nodules, and the swelling and redness. So this is what the PrEP pipeline looks like. It's very exciting. We're moving now into a time of access, hopefully, and rollout. And as we do this, we really do now have an a la carte menu where we can start to say, does oral PrEP suit me better, or is it a 2-monthly or a 6-monthly injection? Am I going to be better with a vaginal ring? And there are pros and cons, and we can really tailor this to the individual. And this is lovely work done by Alzette Rousseau in our organization to say the PrEP users differ. There's social PrEP users for which, they want to come in groups. There's the convenient PrEP user who may want to have it couriered because they really don't want to have to get out of bed and go to a clinic. There's the independent PrEP user. There's the discreet PrEP users. In other words, they're different folks who need different strokes when it comes to their PrEP. And lastly, my last few slides are really about how we then deliver these options. And there is huge movement now to not only offer it in facilities, but actually get out into the communities and say, how can we get PrEP to the people who need it most? And this is our project where we really are trying to get PrEP out to everyone. We are starting to see improvement in persistence by making sure that people can access their PrEP everywhere. And that starts to improve people's access and ability to use PrEP. This is a little, this is a poster which was shown to us in R4P in Lima. In Sao Paulo, they actually have ATM machines giving out PrEP, and this is making a huge difference there. And the reason is because we really have not scaled up PrEP the way we need to. So you can see on the global side, we need to be up to 21 million by 2025. And in fact, by 2022, we were nowhere there. We're at about 6 million at the moment, and there's a lot of work to be done in this regard. Nora Rosenberg showed in her study recently published in CID that in order to get 250,000 infections averted in our region, we're going to have to offer PrEP to 26 million adolescent girls and young women. So this is the scale we need to reach in order to do this. So with that, Mona, I will sum up to say that I believe our prevention is moving in the direction of precision and choice, where we think about the drug and its modality, the choice, the options, the user, what their personality, their season, their disposition is, and how we deliver it is going to differ from person to person. Affordability, availability, demand creation, and access will lead to impact. And I'll end there, and thank you for your attention.
Thank you, Prof. Becker, for such an insightful presentation. Lots of exciting outcomes there. I'll just remind the audience to keep posting your questions in the chat, and we'll get back to them in a moment. And over to you, Dr. Davy.
Good afternoon, everyone. I am delighted to be here today to present with LGB, my mentor, on a lot of things, and so it's very exciting to be able to follow up from her. And I knew that she would give the history of PrEP and all of the things historical, so I can focus more on the specific population that I work with, which is PrEP in pregnancy and lactation. So the title is Empowering Mothers to Protect Themselves and Their Infants, the Role of PrEP in Pregnancy. And thank you to the GIFT team and Joanne and Mona for inviting me to be here today. So I'm going to focus specifically on the population of pregnant and postpartum or lactating women, and focus on the HIV incidence in this population, the impact of HIV transmission, acquisition on vertical transmission, present updated PrEP and vertical transmission prevention guidelines in South Africa, and present results from our recent PrEP-PP, so PrEP in Pregnancy and Postpartum cohort study. And then really focus on the ongoing trials to improve PrEP effectiveness, interventions, and products specifically for pregnant women. And really talk about how we can work together and collaborate towards the elimination of maternal HIV and vertical transmission. So in the last minute it took for me to load up my slides and say thank you, a young woman was infected with HIV. Every week, about 4,900 young women become infected, and girls 15 to 24 are twice as likely to be living with HIV than men. In South Africa, we have the largest HIV epidemic in the world, and women and girls accounted for 64% of all HIV in the last year. 6 and 7 infections are among adolescents, are among young girls 15 to 19. And what happens during pregnancy and breastfeeding in the same population of young women and adult women, that we find a high HIV incidence in pregnancy and breastfeeding. So in this forest plot of 37 studies, mostly in our region of Southern Africa, we can see that the incidence in pregnancy, the pooled incidence overall in Southern Africa was 4.2 per 100 women years. And you can see comparing pregnancy, breastfeeding, and pregnancy and breastfeeding together, the HIV incidence was high, above 3.5 per 100 person years. And you can read more from this study from Graybill et al. Published a few years ago. Overall, pregnant and breastfeeding women are also 2 to 4 times more likely to acquire HIV than non-pregnant or breastfeeding women. And the key reason here is that it's a key question that I get every time is why? What happens when you get pregnant? What happens when you're breastfeeding? And why do you have an increased risk of HIV acquisition? So if you've ever been pregnant, you know that you have hormonal changes, severe hormonal changes, including increased estrogen, progesterone, and cell receptors in your genital tract. Immune adaptations as well, including activated innate immunity, suppressed adaptive immunity, reduced NK cells, and alterations overall in your vaginal microbiome. So this group has also presented, the GIFT group has also presented a lot about the vaginal microbiome and the importance of a healthy microbiome and NK cells in preventing HIV acquisition. STIs, when STIs are high, when there's a high prevalence and incidence, including bacterial vaginosis, it's also a risk factor of HIV acquisition and onward transmission. And postpartum, especially during vaginal birth, there's trauma, micro, macro, caused by vaginal delivery and dryness in the postpartum period. And breastfeeding can lead to low levels of estrogen, and plus persistent inflammation postpartum that are part of the biological factors. In addition, there's socio-behavioral factors, condomless sex before, during, and after pregnancy, sexual networks, intimate partner violence, stigma, and substance use, including alcohol use, may increase risk of HIV in this population. In this UNAIDS report, the causes of vertical transmission of HIV globally, 1 in 4 infant infections is attributed to incident or new maternal HIV acquisition. In our region of Eastern Southern Africa, you can see that 1/3 of infant infections are attributed to incident maternal HIV. And if you only remember one thing today, is that we cannot effectively eliminate vertical transmission of HIV without addressing the incidence of HIV. So just by treatment alone, we will never be able to reduce and eliminate infant HIV. So we need to do both primary prevention, which is preventing women from acquiring HIV during pregnancy and breastfeeding, and secondary prevention, which is getting women to take their antiretrovirals, become virally suppressed during pregnancy and breastfeeding. So in our region, there were 29,000 infant HIV infections from incident HIV, and 16 infant infections were in East and Southern Africa, which is over half of the global cases. What about STIs? I mentioned earlier that STIs are a problem in pregnancy, and in this paper that was published by my colleague Dorothy Niemba a few years ago, you can see really high rates of STIs among women living with HIV and women without HIV, including chlamydia, gonorrhea, trichomonas, and co-infections. And current STIs are managed syndromically which is easier because there's no laboratory access and no delay in treatment, but may miss a majority of asymptomatic STIs, especially in pregnancy, and vaginal discharge is a poor predictor of an STI, especially in pregnancy. So why do we need to include pregnant women in research? Really, in the past 5 years, has been a conceptual shift. And the PHASES study with which I work is really focusing on the shift from focusing on pregnancy as a vulnerable population to a complex population. And I quote from their report that you can take right here from the QR code, is that all people deserve safe and effective medication over the course of their lifespan, including during pregnancy, and deserve an evidence base adequate to that fact. And so instead of protection from research, what we want to advocate for is protection through research and engagement of pregnant and breastfeeding women, including adolescent girls, through the research. And instead of a presumptive exclusion, we want a fair inclusion. And informing women about availability of research studies, including implementation science studies that are ongoing around PrEP. So going into oral PrEP, as LGB presented earlier, oral PrEP is safe and effective for the general population. When I started working here, I really wanted to know, was it safe also in pregnancy and breastfeeding? And we conducted the study that was published last year. And you can see here on the graph, when we compared live birth, preterm birth, infants that were small for gestational age, pregnancy loss, and the composite birth outcome, there was no difference in the pregnancy outcomes, both based on objective levels of tenofovir diphosphate in pregnancy with almost 500 participants. And this is similar to data from Kenya and a recent systematic review that was also published earlier this year to show that there's low concentrations of oral PrEP secreted in breast milk as well. So we can confidently say that oral PrEP, TDF, FTC is safe to take while pregnant and breastfeeding. We created these posters that are now in the Western Cape in the province, really to move from just focusing on treatment to focusing on prevention as well. And prevention of vertical transmission requires treatment for women living with HIV, prophylaxis for HIV-exposed infants, testing of partners, including self-testing, and testing and PrEP for women not living with HIV. So you can see on the right of this poster, we added in, if you're living without HIV, test frequently and take PrEP, a pill to prevent getting HIV. And we hope as injectables and vaginal rings become available, we'll be able to update this poster and update our awareness campaigns again to include other methods. In addition, we talked a lot about the management of STIs and how to prevent HIV acquisition and transmission. So in the past year, the policy has changed. The past 2 years of policy have changed in South Africa. In 2016, pregnant and breastfeeding women were excluded from PrEP guidelines, and we actually had to receive SAPRA, or regulatory approval, to include pregnant women in our study that started in 2018. And the phased implementation in 2019, from to date, 2019 PrEP was in pregnancy was included, and in 2021 there was further guidance about how to provide PrEP in pregnancy to pregnant women. 2017, the WHO recommended that PrEP should be offered to all women, including pregnant and breastfeeding women. And they said that there was no safety rationale for disallowing use. And here are the guidelines that were updated in 2021. Zappy ring, currently pregnant women are excluded. I'll present some of the research, but it's okay to use postpartum. And Caballet, pregnant and postpartum women are not contraindicated, and the guidelines have been developed and disseminated around injectable cabotegravir. This is from the NDOH presentation, really focusing on the risk-benefit. The risk of contracting HIV is high, as I mentioned before, and the risk of taking PrEP, including injectable PrEP and vaginal rings, is very low. There's low risk of adverse effects or any impact on the infant. So the key message is really that the benefits of taking PrEP, any method, during pregnancy or when breastfeeding, far outweighs the risk of any possible harm to the mother or the infant. And last year, the good news is that the guidelines for vertical transmission prevention also includes guidelines on PrEP and new PrEP indicators as well. And the ANC reported at the national level. And so we're very excited to see and be part of these new guidelines that to allow for PrEP to be provided and to actually have indicators for this provision at a national level. Here are some of the guidelines, and you can see here for follow-up, even in postpartum, PrEP is included in the guidelines, which include breastfeeding support, HIV testing, and STI screening, and PrEP alongside family planning. Now I'll talk about the results from our PrEP PP cohort, which is a study run by myself and my colleague Landon Meyer at UCT between 2018 and 2023. You can see here there was an observational cohort of 1,300 pregnant and breastfeeding women that were 16 years and older. The final paper was just released in Lancet HIV last week, so it's a QR code here. And we followed women through 12 months postpartum to evaluate the proportion of people who initiated PrEP, the proportion retained, and the proportion who adhered. And this is a mixed methods evaluation that allowed participants to start or stop PrEP at any time. In this, the first antenatal visit, we enrolled 1,200 people and 84% initiated PrEP. The median age was 26 years, median gestation age was 21 weeks. Most were sexually active and reported recent condomless sex. 60% were unmarried or cohabiting, and over half did not intend to get pregnant, really highlighting the need for integrated family planning contraceptive services within HIV services as well. A third were unsure of their partner's serial status. 13% reported intimate partner violence, and a half reported substance use, mostly alcohol use in the last year. However, only a quarter had heard of PrEP before. When we looked at correlates of PrEP initiation in the study, we could see that women who were diagnosed with an STI, chlamydia, gonorrhea, Trichomonas vaginalis were more likely to initiate PrEP and to continue on PrEP over time. However, stigma and being married or cohabiting were inversely associated with initiating PrEP. Even though married and cohabiting women, a third did not know their partner's serial status, highlighting the need for couples HIV counseling and testing. In this cascade, we can see that drop-off was pretty rapid. Even though 84% started on PrEP, the continuation dropped from 68% who continued at PrEP at 1 month to 39% at 6 months. And you can see here over time in the red box how many continued over time. And in the postpartum period, when women were no longer in antenatal care, we saw a pretty extreme drop-off of PrEP continuation. And so here where we define persistence on PrEP as returning for repeat prescription after baseline, you can see that over time, postpartum women and the light pink was significantly lower. So 59% of postpartum women at 1 month versus 74% of pregnant women continued. And that continued all the way through month 6. And the odds ratio was 0.31. To improve this persistence, we're now conducting biofeedback, including urine tenofovir testing and differentiated PrEP delivery in postpartum, including rapid queues and community delivery with self-testing, and this evaluation is in progress. When we looked at PrEP persistence over time, reporting a side effect at 1 month was associated with decreased odds of PrEP persistence. And 20% said that they had stopped because they felt badly taking PrEP. Remember, this is also during pregnancy when women may also experience concomitant nausea and vomiting at the same time. And being a higher gestation at PrEP start or ANC initiation, lower education were also associated with poor PrEP persistence. Here in the Lancet HIV paper that we published last month, what we found is that most of the seroconversion in our PrEP PP cohort were due to discontinued use in the postpartum period. So we only had 1 seroconversion out of 16 in pregnancy, and we had 15 in postpartum. 14 of these women had discontinued PrEP, and 2 were never on PrEP, really highlighting the importance of continuation on PrEP through postpartum. The barriers listed here are mostly logistical, daily pill-related, or sociocultural, and really changes in sex risk, especially in the postpartum when there may be an abstinence period, anticipated stigma or experienced stigma, interpersonal relationships and violence, access and migration in the postpartum period, demands of a newborn, and side effects were all barriers that we found in our qualitative interviews with pregnant and breastfeeding women. So in our PrEP-PP studies, there was a high uptake of PrEP use in this population. We didn't need to use any risk scores or assessments to identify women at risk. Women self-identified whether they were at risk and needed PrEP or not. We also found that PrEP is safe, and our pregnancy and birth outcomes did not differ, including using objectively measured measures in the blood. STI prevalence and incidence were very high, and the STI treatment also improved PrEP use over time. We also found in future implementation studies that we implemented after PrEP-PP that it was acceptable and feasible to integrate PrEP care into antenatal and postnatal care. The challenges were really continuation and persistence in postpartum and translation of the guidelines in practice. We found that there's really a need for mentorship of antenatal staff, including nurses and midwives, to deliver and promote services in antenatal, postnatal care, and family planning services, and STI care, and guidelines that simplify and allowed for differentiated PrEP deliveries by all PNs, professional nurses and midwives. We are now implementing a stepped care study, and I think that Joanne had asked this question in the chat. What we learned from the SEARCH trial that was really providing differentiated services in Kenya and Uganda is the need for choice, not just choice in PrEP, but choice in different delivery. And so this is a two-stepped randomized trial in 750 pregnant and postpartum women. And we're evaluating a stepped care package in which step one, people receive a self-test for their partner and themselves, and counseling on recent adherence using the urine tenofovir test. So in the photo on the right, you can see the two tests that were used by the participant, her partner, and the urine tenofovir result on the right, compared to standard counseling and testing. And then in step two, in those who discontinue PrEP and AIM-1, they get a choice. So not everyone gets a choice. It's really those who are struggling in typical clinical PrEP care to get home delivery, community pickup, or rapid PrEP collection in the clinic with choice and testing method. And we're going to be evaluating these results early next year and comparing this to no choice at all in a postpartum population. And we look forward to sharing those results early next year. So as LGB presented earlier, we have great new modalities and differentiated delivery to reduce the barriers to daily oral PrEP. That none of these are a panacea, but obviously we want to make sure that people have a choice in injectable CAB, lenacapavir, dapivirine rings, and differentiated PrEP delivery, including multi-month dispensing, pharmacy community, rapid queues, self-testing for PrEP pickup. In a study by Lee Johnson and colleagues, we modeled the benefits of cabotegravir in pregnancy, and in the Tambisa model, they found that there would be 1.3 million new infections in South Africa, including 100,000 in pregnant and breastfeeding women, 17,000 in infants at or before birth, and 35,000 in children through breast milk. In this model, they used 3 scenarios, and you can see if only oral PrEP is provided, which is on the left of the figure, there'll be about a 9% reduction in HIV incidence. With CAB-LA only, there'll be about 40% reduction, and a choice, again, there'll be a similar choice between oral and CAB, and we would see about a 40% reduction. So hopefully this model will help improve delivery of cabotegravir and oral PrEP in this population. I think Joanna also asked this question, if there was differences in different populations. And my colleague Nafisa Wara published a study recently in JIAS comparing oral PrEP pregnant and postpartum women in Kenya versus South Africa. And you can see community delivery was significantly higher in South Africa, with 60% of women saying they wanted community delivery compared to 25%. And this is what in Kenya, and that's what we're currently evaluating in our SCOPE study. In an ongoing implementation study run by Desmond Tutu, the study is enrolling young people 15 to 29, and they're offered oral PrEP or cabotegravir. And through September of this year, we had 58% pregnant and breastfeeding women, 83% started CAB, and 27% started oral. And we're interviewing them right now, and we should have a data next year, including on birth outcomes and persistence. But women reported they liked the ease of use, long-acting protection, and they reported they were very likely to continue use. The dapivirine ring has been shown to be effective and safe in two MTN studies, the DELIVER trial, and third trimester and first trimester outcomes and complications were no different. The EMA, the European Medical Agency, has recently approved the DAPI ring, and we're hoping for updates in South Africa again as well. And more research is really needed about the vaginal ring. You can see here that 87% of women wanted to continue oral PrEP over vaginal ring use in both South Africa and Kenya. And 75% of women reported they would like to switch to injectable PrEP. So we really need to understand what the barriers are to DAPI ring use. In both the cabotegravir and the lenacapavir trials, we found that they're safe and well tolerated. And the takeaway messages are really that we really need to have importance of choice. Most people preferred long-acting PrEP over oral PrEP. And there are key differences in populations between South Africa and Kenya. So understanding the context is important. I'd like us to work together really today to improve access to and counseling for effective PrEP use, improve continuation and postpartum, ensure testing of postpartum women, and ensure choice and access to methods and differentiated delivery over time, and then improve education in the community and providers to encourage PrEP in this population. And I want to thank my team, my dream team listed here from UCT, and Desmond Tutu and UCLA. Thank you so much.
Thank you so much for that very interesting presentation. A reminder to our audience to keep posting your questions in the chat, and we'll get to them in a moment. So Prof. Becker and Dr. Davey, thank you so much for your valuable contributions to this discussion. So we'll open up the discussion and take some questions from our audience. Please keep posting your questions and I can put them to the panelists. I think I can go first. For me, today's presentations have sort of highlighted the need for a comprehensive approach to tackle the HIV epidemic, focusing on new prevention tools and their use in high-risk groups, including pregnant women and breastfeeding women. Together, these talks sort of emphasize the need for tailored interventions that balance efficacy, accessibility, and adherence to maximize impact in preventing HIV transmission. I mean, we can see that identifying women at increasing risk for HIV, at increased risk of HIV acquisition is very critical for timely intervention. And I think this is where the genital inflammation test, or GIFT, comes in by detecting biomarkers of inflammation. I think GIFT can potentially serve as a point of care tool to flag women who may benefit most from targeted pre-exposure prophylaxis strategies, such as the oral PrEP or the emerging long-acting options that Prof. Becker has spoken about. Our team is currently exploring integrating GIFT into antenatal or reproductive health services, and how this could significantly enhance our ability to prevent new HIV infections and protect mothers and their infants. So we're very excited that we can have this link. So I have a question for Dr. Devora. How do we improve access to these products outside of clinical trials for pregnant women and breastfeeding mothers in SA?
Yeah, thank you, Mona. It was a great question. Right now, oral PrEP is available to everyone. And so we've seen a big change in the past 3 years, in that there's indicators now, like I mentioned, for antenatal care, and oral PrEP is available. When you're speaking about the DAPI ring and injectable PrEP, cabotegravir, lenacapavir, there's a lot of advocacy being done on a national and regional and international to make sure that these products become available. And LGB and I are probably at the forefront of advocating that pregnant women do become part of the implementation after the clinical trials, because of the double prevention benefit of the pregnant woman and her infant. And so we continue to do this advocacy, and right now a lot of it is really the cost. And so we're hoping that the cost effectiveness data that we are sharing will also help reduce the cost of and improve access to these products outside of clinical trials and implementation science studies.
Oh, thank you. And Prof. Becker, do you think we need other options, or is this it? Do you think we've arrived, or can we more or innovate can we keep innovating?
Thanks, Mona. I think we do have to keep innovating. Sadly, when we get antiretrovirals or antibiotics into our hands, invariably those antibiotics or antivirals eventually lose their value because of resistance mutations. Hopefully that isn't going to happen soon, but I think we always have to be thinking that this is possible. So continuing to look for new antiretroviral targets is important. I think also exploring immune-based PrEP, because that takes us away from antiretrovirals. And then I started to hint at various options that are already in the pipeline, things like a vaginal film that you stick in the vagina, a bit like a breath film, and it dissolves over 30 days. That may well be somebody's, preference. There are implants on their way as well, which could be as long as a year. So that's going to be very exciting. And, I think, and maybe I'll answer this in a slightly different way, Mona, because one of the questions I get asked all the time is, why would you advocate for a ring that has a modest efficacy when you can say to somebody, use this and it has, X 89% or even 100% efficacy? The point is, any PrEP is only as good as it actually gets used. So if this person doesn't like needles and they don't like swallowing pills, and all they're going to use is a vaginal ring is going to still be highly effective in that individual because they wouldn't use the oral or they wouldn't use the injectable. So this is where that risk benefit or use benefit ratio discussion needs to happen. So one of the things we also have to get much better at is our counseling for choice, helping people understand what their choices are, getting in terms with their own preferences, and then making sure that those choices are available to individuals. So I hope that kind of answers, yes, I think we need more innovation. I'm particularly excited about the monthly pill. I think a monthly pill is definitely going to be very acceptable to a lot of people.
Yes, I agree with you. I think it's easier to adhere to that than taking something that needs to be taken every day. So how affordable and accessible will lenacapavir be for populations most at risk of HIV? I mean, particularly in resource-limited settings. And do you think that lenacapavir vaccine will be available to those in need, like, for example, in South Africa? And how soon do you anticipate that development?
Well, if Gilead knows what's good for them, definitely in South Africa, because we won't rest until it comes to South Africa for this basic reason that 25, well, let me say we had at least 5 Purpose 2 studies as well. So you can say 30 sites, 30 communities, 30 times a few hundred people in the country participated in the phase 3, and therefore I think they have every right to expect to see it come to the country and be available. So we are definitely advocating in that direction. How affordable it is going to be is going to depend quite a lot on Gilead Sciences. Happily, there is move afoot to get it into a generic form. So they have given voluntary licenses to 6 pharmaceutical companies. Sadly, none of them in South Africa, but certainly there is one in Egypt, which is African-based. There are a couple, 3, I think, in India, and then the others in other parts of the world. The generic should come online in at least, a year to 2 years. In the meantime, Gilead has told us they will give us lenacapavir at tiered pricing. So in other words, a cheaper originator version that is supposed to be, in the ballpark of affordability for our countries. Happily, what I'm hearing is that, government and policymakers may tolerate a little more cost because of the high efficacy. So you're getting good effectiveness, and therefore you could tolerate it being somewhat pricier. But of course, at the end of the day, it's going to depend on how much our governments can afford. So fingers crossed. And if that fails, we will take to the streets and raise our voices.
Definitely. And Dr. Devorah, what are the biggest concerns that pregnant women raise when it comes to PrEP? What has been your experience with that regard?
I think safety is the biggest one. Is it safe for me to take? Is it safe for my baby? Will it cause stillbirth and miscarriage? Once we, really talk about the safety, it's the side effects. How am I going to feel on it? Am I going to be vomiting, nausea, vomiting, diarrhea? And then the third is really who will find out. It's not a discrete method. You have to take it home. The pill bottle rattles. People will find out. So it's the disclosure. So that's why I talk about, it's both the safety, but also the stigma. The stigma, anticipated stigma is still a big barrier in pregnant women.
Thank you, Dr. Devorah.
And I would say those are very similar even for non-pregnant people.
Yeah.
I think Devorah raises a good point that stigma, this looks like an antiretroviral, comes in a bottle like an antiretroviral. Will this out me as somebody living with HIV, number one? Or will people think I'm promiscuous because I'm one of those other people using PrEP, which is only for sex workers or loose people? So we have to overcome all, those kinds of concepts. And this is where perhaps an injection in your bottom or in your subcutaneous area, we give it actually in the stomach. Not in the stomach, but in the skin over the stomach is where we give lenacapavir, but it can be given in the thigh or other parts of the body. It goes under the skin. That's obviously far more discreet, right? You get it in the clinic, you walk away, nobody knows. So this is why I think young women and girls really love it. Somebody asked a good question, do we see differing different people wanting different kinds? And I'll just raise very interesting young men who have sex with men in Brazil are frightened of needles, as it turns out. They're not used to contraception or other ways that people give medication, whereas here our young women are so used to getting their contraception in their butts that they've taken to cabaret like ducks in water. But their counterparts in Brazil are like, no, we don't want needles. So this just shows, and yet they're happier to take pills. So every population, I think, is going to be slightly different.
Thank you, Prof. Becker. And thank you all for your insightful questions. I think we've run out of time now. We've come to the end of the webinar and it's time for us to wrap up. So I want to express my sincere thanks to Prof. Becker and Dr. Devi for their valuable input and significant contributions to this important conversation, as well as to the Jive Media team who have been working tirelessly in the background to ensure the webinar runs smoothly without any glitches. A link to an evaluation form of today's webinar has been added to the chat. Please take some time to provide us with your feedback. And our next Women Up to No Good webinars is scheduled for next year. Please keep an eye out on our e-newsletter and social media for more information. Also remember to sign up for the e-newsletter to stay updated on future events. You can find the link in the chat box as well. For those who missed any part of this webinar or wish to revisit it, a recording will be uploaded to the GIFT YouTube channel. In addition, a summary of this webinar will also be available on the GIFT website. You can find links to these platforms in the chat. But once again, thank you all for your participation, and we look forward to welcoming you to the next webinar.